Not at
Faisal
all, not
sir
at
to
all.
give me a chance. Thanks Sanjay sir for being a chairing this session. And we'll be presenting two cases from Jipmer this time. And first case will be presented by Dr. Vishnu, and I will be the moderating the case. And Dr. Saranya, our assistant professor, will be has also played a great part in it. Second case will be presented by Dr. Ram Sugumaran and Dr. Jairam. So we will start the first case. So Dr. Vishnu, please start the case. Dr. Vishnu, you may start. Dr. Vishnu, can you hear me?
Vishnu sir, please unmute yourself. Please unmute yourself, Vishnu sir.
Start. Share.
Shall we start?
Yes,
Um,
yes.
Okay.
Intro.
Okay, Vaibhav, you can go ahead.
Sir, make full screen.
Please
Share.
make the full screen and please make a slide presentation. Yes.
Morning, everyone. Today I'm going to present the case in Neurology Forum. My topic of presentation will be who is the villain, inflammatory or hereditary. So we will start the case presentation. So history is like Mr. R, 37-year-old male from Pondicherry. He is educated till 10th standard and is painter by occupation. And information was given by himself and his mother. Chief complaints was difficulty in walking for 33 years. From his 4 years of age and weakness of both lower limbs for 17 years. From his 20 years of age, and he is having worsening of both lower limb weakness for last 8 months, and he is having pain in the right cheek region for last 8 months, and he is having weakness of both upper limbs for last 5 months. So first I will start with his birth and development history. So he was a firstborn child of a second degree consanguineous marriage by normal vaginal delivery. He had a history of delayed cry at birth, and he had history of delayed motor developmental milestones in the form of standing without support at 2 years of age, standing with support at 2.5 years of age, walking at 4 years, running at 5 years, and rest all his language, social milestones, and his relationship with friends and peers was normal. So only he had motor developmental delay. So I'm furthermore describing about the motor developmental delay. Actually, mother used to support him to stand. If he is not supported, he will collapse to the ground without support. Started to walk at 4 years of age, and he was not able to run at pace with his friends, and he was a slow runner. But although he had all these symptoms, he was able to drive bicycles and was able to climb stairs and walk to the school. And he was able to grip footwear. So this continued until his age of 20 years. So until 20 years, he was fine. Then all the weakness of both lower limb started for after the 20 years of age. That is for last 17 years, he is having symptoms of insidious onset, progressive, symmetrical, and difficulty in insinuating the feet into the slippers. Slippage of slippers with awareness, and he had tripping of toes while walking on level ground with history of falls. Almost 1 to 2 per year he was having. Then simultaneously, he has noted he had thinning of lower limb muscles in the region of calf and foot. So this was there for last 17 years from his age, 20 years of age. Then over the last 8 months, this is very significant. Last 8 months, he is having weakness of again worsening of the weakness of both lower limbs in means of he had developed proximal weakness. So he had difficulty in getting up from squatting position, and it was associated with flatness of limb. And for last 7 months, he is having difficulty in climbing upstairs. Last 3 to 4 months, he has difficulty in climbing downstairs. And past 2 months, he is having buckling of knees. And because of that buckling of knees, he is having associated falls. That is about 2 to 3 times per month. And because of this flailness of limb, he was unable to walk long distances. and he was having recurrent buckling. And to prevent tripping, he used to walk with feet off the ground and stamp it on the ground. So high stepping gait was there. And last 8 months, he is also complaining about he is having shooting or lancinating pain on the right cheek, which lasted for 1 to 2 seconds. And he's having recurrent episodes, which was aggravated on touch, cold water, cold air, or shaving, and it was not associated with any sensory deficit on the facial area. These falls were not associated with any giddiness or loss of awareness or vertigo or involuntary movements of limbs or any palpitation, excessive sweating, or transient loss of vision. He has sensory symptoms by means of like last 8 months, he is having swaying while washing the face, which worsened on darkness, on closing the eyes. But it was not associated with any numbness of both lower limbs, and he was able to appreciate hot and cold sensation of water and pinprick sensation, and it was not associated with any paresthesia or burning sensation. This was the timeline for the lower limb weakness. So when he was at the age of 3 years, they started to notice that he is having difficulty in walking, and at the age of 20 years, he noticed he has slippage of slippers and tripping of toes. And by age of 37 years, that is 8 months back, he had worsening by means of getting up from squatting, climbing stair difficulty, and increasing tripping. And again, before like 6 months back, he noticed he has difficulty in climbing downstairs. And almost 2 months back, he started having buckling on walking. So almost 17 years, he had static distal weakness. And over the last 8 months, he is having proximal weakness and buckling of walking. So over the last 8 months, he has worsened. Weakness of both upper limbs for 5 months. It was insidious in onset, gradually progressing, distal and symmetrical. Difficulty was by means of he had difficulty in holding tumbler, paint brushes, buttoning and unbuttoning, mixing foot.
Vishnu, your sound is not coming.
Sir, we cannot hear you, Vishnu, sir.
Vishnu, we are not audible.
Of limbs or cramps. He didn't have history of fatigability or fluctuation of the weakness. He didn't have any diurnal variation. He didn't have myotonia, shortness of breath or palpitation, dark colored urine, worsening after exercise, cranial nerve complaints, or bowel and bladder disturbances. There were no history of any cough, fever, diarrhea, weight loss, any toxin exposure, or any rashes or photosensitivity. Current status is he is able to get up from the chair with one hand support, required two-hand support and push from the behind to climb best footboards. And he was able to walk without support, but he had recurrent buckling of knees for last 2 months. So this was the overall timeline from 1991. That is, he is having at the age of 3 years, he is having difficulty in walking. At the age of 20 years, he noticed he is having symmetrical lower limb distal weakness. And by age of 37 years, that is 8 months back, he noticed he is having proximal lower limb weakness and worsening distal weakness with posterior column sensory sensations. And over last 5 months, he is having upper limb weakness, that is was distal. And over like last 1 month, he was admitted under our neurology. So last 8 months, he is having rapid worsening. So past history is a non-case of diabetes mellitus for past 1 year. Personal history, he used to take alcohol for last 20 years, but he stopped 1 year ago. About 90 ml per day. He is not a smoker. Sleep, appetite, bowel and bladder habits was normal. This was the family history. He didn't have any significant family history prior. Summary, a 38-year-old gentleman with motor developmental delay, insidious onset, gradually progressive, symmetrical, with history of recent worsening, sensory motor, lower motor neuron quadriparesis, with distal predominant than proximal. Lower limb was involved first, which was distal followed by proximal, and then upper limbs, which was distal only, with wasting and bilateral foot deformity. Right trigeminal neuralgia was there, but there was no significant family history, and there were normal cerebellar findings, history, and autonomics and higher mental function. So localization, since there is an involvement of, they are telling about the posterior column sensations are involved, and there is pure motor weakness involving distal and proximal. first my localization will be nerve plus root. So first will be, I will put as hereditary, because since he is having history from the birth, so I will put HMSN as my first differential diagnosis. Points favoring HMSN was both sensory and motor involvement is there, and there is symmetrical involvement is there, and it is lasting long duration from birth they have found, and it is more distal than proximal, and there is a deformity, and there was a motor delay history. Point against HMSN was there is a subacute worsening. Last 8 months, some worsening is there, and there is history of sensory ataxia is there, and there is history of trigeminal neurology is there. My second DD will be CADP and its variant. So points towards CADP will be sensory motor involvement is there, there is symmetrical involvement is there, and there is progression for last more than 8 weeks. There is subacute worsening is there last 8 weeks, and there is sensory ataxia. Points against CADP will be there is a deformity, and there is a motor delay history, and there is history of trigeminal neuralgia. If we are not considering that sensory symptom as a predominant symptom, like the posterior colon symptom, it will be a more or like a pure motor neuropathy with proximal and distal involvement. So I like to consider that part also, because we are yet to examine him. So if it is a pure motor like differential diagnosis you have to put, then one differential diagnosis will be cerebral palsy, because he had an history of delayed cry from, and symptom is from birth, and he had history of foot deformity. But points against is it was slowly progressive, and there was an history, definitely history of looseness of the foot was there, and other milestones was normal. Only he had motor developmental delay, and there is a recent history of subacute worsening, sensory ataxia, trigeminal neuralgia, and that sensory. Whether that sensory involvement is significant or not, we have to examine and see. Other DD, if it is pure motor, will be anterior horn cell, like SMA. Points towards it is motor predominant, symmetrical, and is there lasting for longer duration, and it is more distal than proximal, and there is a history of deformity and motor delay. Point against will be sensory motor, subacute worsening is there, sensory ataxia is there, trigeminal neuralgia is there. Then considering more distal than proximal weakness, distal myopathy can be a possibility. So it is points towards is motor predominant, symmetrical, longer duration, and there is a history of motor delay. And against will be sensory motor, subacute worsening, sensory ataxia, and trigeminal neuralgia. So with this all this history, we have to confirm our findings with our examination. So we'll go to examination. On examination, patient was conscious. Vitals BP wise 110/70 millimeter of mercury. Pulse rate was 68. Respiratory rate was 18. There was no orthostatic fall in BP. No neurocutaneous markers. No other hypopigmentations on the skin. And there was history of high arched. There is high arched foot and pes cavus and champagne leg deformity. So this was his leg. It was showing high arched patches. Pes cavus was there, and there was significant wasting of the lower limb. Thigh and lower limb muscle was there. CNS examination, higher mental examination was normal. Since he had a history of trigeminal neuralgia, we examined properly cranial nerves. Cranial nerve was normal. Fundus was normal. Fifth nerve examination, motor and sensory was normal. There was no facial weakness. Hearing and vision was normal. Motor system examination revealed he had wasting of distal muscles of small muscle wasting of hand was there, and hypothenar eminent wasting was there, and there was wasting of lower limb muscles, basically foot muscles, and he had wasting of calf, and he had wasting of uh, distal thigh muscles also. His tone was, he was having flaccid. Tone was reduced in all four limbs. Then about power, he had proximal shoulder and elbow, almost he was having full power, but there was weakness for elbow extension, and there were more distal weakness than proximal. So his pronation, supination was weak, and wrist flexion and extension was more weak, and his hand muscles was weak. So there were more distal weakness than proximal weakness in upper limb examination. In lower limb examination, again, he had weakness of hip and knee, almost it was 4/5, but there was significant dorsiflexion weakness. He was not able, he was like 1/5 weakness only was, 1/5 only was there, and there was significant weakness for inversion and reversion. So here also there was significant distal weakness more than proximal weakness. This was the power examination. So he was this was proximal the distal weakness, wrist weakness. He was having almost 3/5 only weakness for wrist extension and flexion. This was examination of lower limb, basically distal weakness he was having. So dorsiflexion more than plantar flexion, he had dorsiflexion weakness. We have done nerve biopsy for him. That was that bandage was applied for that nerve biopsy. So pardon for that. So deep temporal reflex, actually he was having significant hyporeflexia. In upper limb it was 1 plus, but lower limbs he was having areflexia. And plantar reflex, superficial reflex, plantar reflex was bilaterally flexor. This was a reflex examination, angle reflex. We are doing geodesic maneuver, still we are not able to elicit uh, reflexes. This was his gait. So he was able to wake up with one hand support, and while walking, he had actually high stepping gait with toes touching feet first, and he was having stamping gait with normal turns. So he was having significant dorsiflexion weakness. On walking, he was stamping and walking with high stepping gait. So other neurological examination continuing. His sensation, there were impaired sensations. Both, or basically pan modality sensation loss was there below bilateral knee and elbow. And Romberg sign was positive. Skull and spine was normal. And other point to be noted that he was having bilateral ulnar and common peroneal nerve palpable. With the rest other palpable nerves was normal, could not be palpable, and he was not having any hypopigmented patches. And other system examination, abdominal examination revealed no organomegaly. Cardiovascular system and respiratory system examination was normal. So, summary, we are coming 37-year-old gentleman with insidious onset, gradually progressing, symmetrical, sensory, basically pan model involvement is there with element motor quadriparesis, lower limb followed by upper limb, distal followed by proximal, normal cranial nerves, no coordination difficulties, autonomics and function was normal. With the history of recent worsening for last 8 months and history of trigeminal neuralgia, and on examination, we found out he is having nerve thickening, hand sensory loss, hyporeflexia, pes cavus deformity, and significant atrophy of muscles with signs more than symptoms. That is the crust point. So again, we have objectively we have found out that he is having sensory deficit also. So our differential diagnosis again came to nerve plus root alone. All other pure motor DDs we have eliminated. Now we are coming to two DDs, basically nerve plus root involvement, HMSN. So points towards HMSN is sensory motor, symmetrical, basically having long duration with distal more than proximal, and there is a deformity and there is history of motor delay. Against this, last 8 months, he is having subacute worsening, and there is sensory ataxia, and there is trigeminal neuralgia.
Can we
Then
just take a
points
pause
favoring.
here, Vishnu?
Yes, yes, sir.
Can we just take a pause here? Any questions, any comments so far?
The only comment which I would like to make is with regards to this trigeminal nerve pain. I have heard Peter James Dick remark that this is could be a feature of CIDP. But more than that, I do not know. I heard him remark in one of the meetings that this nerve pain could be a feature of CIDP.
Okay, so
I
we will
don't know
come to
how
that, sir,
helpful it
because
would
that is
be.
the one thing till now which is totally off.
Yeah,
Right.
but he has said it could be. As all of us know, Peter James Dick is an authority on peripheral nerve. And he mentioned in one of the conferences, one of the meetings, AAN meetings,
Yes,
that this trigeminal nerve involvement could be due to, could be a feature of CIDP.
Can this be part of HMSN, sir?
Rest of the thing is HMSN, yes, of course. But as
So
you
that's a trick here. And
as you said,
the
it is
the
between the
basic
two.
question, the basic question here is whether he has HMSN. So hereditary motor chronic disorder or not, there is no doubt about it. That is a chronic disorder. The question is whether he has added on CIDP or not. As you rightly picked up the question. So with that comment, that whether he has CIDP or not,
Just
or
one second.
whether it's just a plain simple subacute worsening of the HMSN, if so, then why? So with that comment, we
I
will
think we'll have
continue.
to go with the investigations to
So
decide what
yeah.
this could be.
Any history
Continue,
of
Vishnu.
No, there are others comments. There are comments from others. Yeah.
Justin, sir.
I just want to know whether he's a chronic alcohol consumer. Any
Yes.
other history of high risk behavior in this patient?
Vishnu?
No, sir. No, sir. No high risk behavior history, sir.
Sir, Justin, sir. Hello. Hello.
Yeah. Yes.
Sir, Justin.
Yes, Justin,
Yeah,
go
Justin.
ahead.
Justin, please tell.
Sir, basically, if the patient is having a positive symptoms, that rules out its genetic pathology. If patient doesn't have a positive symptoms, mostly it's an acquired one. The both condition, one is genetically determined, another is immunologically determined. If there's genetically, both will have a trigeminal neuralgia also. There are genes reported with HMSN with trigeminal
Yes.
neuralgia. Same way CIDP, as you mentioned, Professor Natarajan sir, CIDP with trigeminal neuralgia also. The history, if you have a positive symptoms, then you'll go for a CIDP with the trigeminal neuralgia. If patient doesn't have a positive symptoms of sensory, then you'll go for a genetic
So sensory
determined
test will
HMSN.
take as a positive symptom or negative symptom, sir?
Professor
Yes,
Vaibhav
sensory
and
test.
Professor Sanjit, Professor UK Mishra has joined. He is there. Maybe we could invite him for his opinion.
Yes, sir, definitely.
Professor UKM, can you give your comments, please? He's gone.
No, whenever there is acute worsening, whenever patient is rapidly worsening, then we should find.
Sir, you're not audible, sir.
Am I audible? No. Am I audible?
Professor Mishra, sir, you're not audible.
Yeah. Okay.
Yes, sir.
Well, am I audible? No, not.
Yes,
Yes,
sir. Yes, sir.
now you are
Okay.
audible very much. And
Thank you.
You're
So I
also
don't.
visible.
Thank you. But you know, if a patient has got subacute worsening, then I would, I would like to think something acquired before considering, genetic disorder. And therefore, if you have got a trigeminal and sensory ataxia, so let's first consider the, rare manifestation of common, common disorders. So that will be more appropriate. You are feeling the nerve, one hand, is it thickened? Probably yes, which is very subjective. And then subacute worsening, again, it's a little, odd with a genetic disorder. So I would like to consider acquired conditions and sensory ataxia. Before considering anything else, we should rule out B12. Of course, it's more of a spasticity rather than neuropathy. But then, sensory ataxia, HIV will be another, and CIDP will be another. but I'm sure there must be something more sinister. Therefore, you are presenting it. So I hold my.
And also a treatable problem.
Yeah.
Yes.
Suitable.
So Vishnu, please continue here.
Yes, I will introduce Dr. Sharanya for presenting about the investigation details of this case.
Good afternoon, respected teachers. We'll be proceeding with the investigations of this patient. The nerve conduction study was performed initially for this patient, which revealed uniform slowing of nerve conduction velocity across all the nerves. And one important point was that there was significant conduction block at the non-compressive sites in this patient. As you can see in the ulnar nerves bilaterally, there was significant conduction block which was seen, and with prolongation of distal latencies. And the sensory nerve conduction studies showed unrecordable sural, median, and ulnar nerves bilaterally.
Yeah, one more additional comment, Dr. Saranya. Just go back to that first slide. First slide.
Sir?
I hope you don't have it in the future slides, but just a comment. The important thing to notice is that NCV is less than 10 almost in all the nerves.
Yes. There was a
Ulnar is the
uniform.
most important nerves to note, and there are conduction blocks. So this NCV, I think you must be having in the subsequent slide that this takes us to a specific variant of the HMSN, right?
Yes. I'll be
So
talking
this,
about that.
yeah, okay, fine. So then I will not comment
So,
here. Yes.
yeah. We have noticed
15 is
that
the
there was
cutoff. Yes,
yeah,
15 is the
15 was
cutoff.
the
Yeah.
cutoff, and there was uniform slowing of conduction velocities in all the tested nerves, and sensory nerves were unrecordable, and there was significant conduction block as well. Then, so in the background of a genetic versus an inflammatory neuropathy, we wanted a further diagnostic confirmation. We wanted a further clue. So we proceeded with the MRI of the lumbosacral region with the nerve roots. As we can see here, there is significant thickening of the lumbosacral nerve roots and the cauda equina, and with so there was significant thickening of the nerve roots with contrast enhancement, as you can see in this image. Then we proceeded with the CSF analysis for him, which revealed a normal opening pressure, and there was neutrophilic pleocytosis with normal glucose and significantly elevated protein of 883 milligram per deciliter. So again, we are at doubt. So whether it is genetic or whether there is any acute component to it, and since there was significant protein elevation, MRI showing significant nerve root thickening and enlargement with contrast enhancement. We further proceeded to rule out any acquired cause of a neuropathy in him, where the CBC with ESR and CRP was normal. Renal and
Just
liver
one comment
function
about the
tests.
NCS. Somebody has asked also actually regarding blink reflex. We did not do the blink reflex in this case. We should have done it. Yeah, because
Okay.
I learned it about later on. So we should be doing the this blink reflex also in CIDP and HMSN cases. Yes. Somebody has asked also.
CSF study, was there any abnormal cells? There was 47 cells. Did you send it for any special stain, cytospin, etc.?
Yes, a malignant cytology was sent, sir. That was negative, sir. Yeah. Okay. So proceeding further, the routine biochemical examination and complete blood count with peripheral smear was normal. Vasculitic panel and other inflammatory parameters were normal. Serum protein electrophoresis with immunofixation did not reveal any monoclonal bands, and urine Bensdorf's protein was negative. Only abnormal finding was an HbA1c was 7.9%, but in hospital sugars were relatively controlled. So since we still had a doubt whether it was an inflammatory or a hereditary neuropathy, we proceeded with a nerve biopsy. As you can see, the gross specimen of the nerve is what we have shown here. It is significantly enlarged. And the biopsy also showed that there was relatively uniform loss of myelination from the nerve fibers with onion bulbs, and only very minimal sprinkling of lymphocytes in the endoneurium, and there was no significant evidence of any vasculitis or any inflammation in the nerve. And
And just a
CD68,
comment here. you can see here the additional report of no evidence of overlapping CIDP.
Macrophages.
So
Yes.
I want to just commend the team that my residents were in constant touch with the Niman's biopsy team. We had personally, on telephonically, and in details in written also, we had communicated detailed histories. This report was given after multiple discussions. So Niman's team also knew about the whole details of this case. Please proceed. Yeah.
So the biopsy did not show any significant evidence of inflammation or overlapping inflammatory neuropathy. They reported it as hereditary neuropathy of the right sural nerve. Then we also could not get a family history from the patient, so we called as family members to a hospital for a review. At this juncture, we noted that the father also had presence of distal wasting of the leg muscles, as we can see in this image, along with mild pes cavus as well. And there is significant thinning of the calf muscles. Also, there was distal wasting of the intrinsic hand muscles in him. And there was history of second degree consanguinity in this patient. So the mother also was noted to have significant wasting of the intrinsic hand muscles along with pes cavus. We did the NCS of the parents also, which showed significant uniform demyelination picture along with conduction block in mother and father as well, as we can see this. There was prolongation of distal latencies, uniform reduction of conduction velocities, and presence of reduced EMAP amplitudes with conduction block in non-compressible sites, with sensory being non-recordable. This was a similar finding which we obtained in the father also. Then we proceeded with molecular analysis for this patient because still we were at a doubt whether it was actually inflammatory or genetic. Then what we got through whole exome sequencing was a duplication in the PMP22 gene, and 3 copy number variants were detected for the same, which was consistent with Charcot-Marie tooth disease type 1A, and it was reported as pathogenic as well. So, summarizing, a 37-year-old gentleman with insidious onset symmetric element type of sensory motor quadriparesis, distal followed by proximal with recent worsening, with generalized hypo to areflexia, with predominant signs more than symptoms, with normal cranial nerves, with history of a recent worsening and associated trigeminal neuralgia, with significant family history in 2 family members, with evidence of demyelinating neuropathy and conduction blocks, and PMP22 duplication positive. We again refined our diagnosis to HMSN, but still we are not very sure whether it was HMSN or whether there was a coexistent inflammatory neuropathy also. So in HMSN, when we reviewed the literature, we found that there are several case series and case reports which have delineated these genes as genes where there have been demyelinating neuropathy with conduction blocks reported. CMT4J, FIG4, GJB1, PMP22 also demyelinating neuropathy with conduction block has been previously reported. CMT4CSH3TC2 with associated inflammatory neuropathy in the biopsy has been reported, and CMT1B myelin protein 0. So these are the genetic variants of CMT where this demyelinating neuropathy with conduction blocks and has been reported. Then coming to the CSF protein elevation in HMSN, this was a paper which was published in the Neurology journal in 2003. So this patient had genetically proven CMT1A, where his MRI was showing thickened and hypertrophic nerve roots with contrast enhancement and other clinical phenotypes fitting with HMSN. So in this, they postulated that the CSF protein elevation in this patient, he had almost 388 milligram percent of protein in the CSF, and they postulated that probably there is leakage, there is a blood CSF barrier disruption, root barrier disruption, nerve root barrier disruption, which caused leakage of proteins from the enlarged roots, causing something like a Freund syndrome, causing a partial block of CSF circulation. So this could have been the cause of protein elevation in our patient also. In this paper, they also tried treating him with steroids and IVIG. Though there was no clinical improvement, the patient had significant reduction of proteins in the CSF following the treatment.
This phenomenon is surprisingly similar to the Freund syndrome, right?
Yes, yes. Yes, sir. Sorry. So again, so we wanted to, since there was an acute reason worsening over the last 8 months for this patient, we tried to treat him because we thought all other reversible causes, we were not able to find out a definite etiology. We tried to treat him with steroids for 1 month, and we gave him a trial of steroids for 1 month. So after 1 month, we did the nerve conduction study. Again, there was no significant improvement. The velocities, the amplitudes, and the latencies were more or less the same, and there was no significant improvement in the nerve conduction velocity, and sensory was still non-recordable, and the patient also did not have any significant improvement in his weakness after steroids. So still, we are at this juncture whether it was an HMSN or whether there was a superimposed CIDP or both he had. We really are still not sure. So I have reviewed some literature on coexistent hereditary and inflammatory neuropathy. In this paper, they had studied 7 cases of genetically proven CMT1A due to chromosome 17p duplication. So in this paper, all of them had an acute or subacute deterioration following a stable period. And they were empirically treated with steroids or IVIG, with some patients having a variable, like positive response, and some did not respond. So here, what they say is if a patient with CMT experiences an acute or subacute deterioration, treatment of coexistent inflammatory neuropathy with immunomodulatory therapy is warranted or to be considered. Also, MR imaging of cauda equina in HMSN has also been reported. In this paper, 10 patients were monitored and with MRI, and spinal nerve root enhancement, especially in the area of the cauda equina, has been found. And they say that the lumbosacral spinal nerve root abnormalities were related to an increased high number of onion bulbs, indicating active demyelination at sural nerve biopsy. And cranial nerve involvement has also been infrequently reported in patients with Charcot-Marie-Tooth disease, especially similar to the peripheral nerve involvement. Cranial nerves can also be involved with concomitant neural foraminal narrowing and enhancement in the MRI. So similar to the peripheral nerves, the cranial nerves can also be enhanced. For example, cranial nerve 5 and 7 have been reported to be involved in patients with CMT1A. But in our patient, when we did the MRI CIS protocol for the trigeminal neuralgia, we found that there was a vascular insult and there was no abnormal thickening or enhancement of the trigeminal nerve. Rather, he had a trigeminal neuralgia secondary to a vascular loop. So, coming to the conclusion, a unique electrographic finding of conduction block implicates the need to consider CMT1A in the differential diagnosis presence with a sense.
I think our signal has broken up. Am I audible?
Yeah, you are audible.
Excuse me.
We cannot hear you, ma'am.
Yes. Certainly. So can I share my slides? Just 3-4 slides more.
So,
Yeah.
all that conduction blocks is not always acquired demyelination. We can also have hereditary demyelination with conduction blocks. This is the message from our case. Now I hand over to Dr. Weibach.
Are my slides visible?
Yes, sir.
So thank you for the opportunity once again. I will quickly take. I will have only three aspects. I will just comments on the inflammation. Second is the genetic aspect, and third is how does these affect the impact? What impact does this have in management? So today's case, I don't think it has much a diagnostic challenge. It was a more of an analytical challenge. So let us discuss one by one. Inflammation. So case had a subacute progression within last 8 months, rapid progression with upper limb involvement. There is no doubt about it. But there is absolutely no doubt also that patient had illness since birth and had a long standing chronic illness on the background. So there are multiple papers, but this type of subacute progression has been discussed in HMSN, but I couldn't find the reason for this, why this happens. Is it some secondary insult or what happens? This has been mentioned in the literature. Second is CSF elevation. It was markedly involved. So Dr. Saranya gave some of the reasons. And third is NCS showed conduction block. Conduction block has been mainly shown with conduction velocities less than 15 in type that CMT type X. But our turned out to be PMP22 duplication. So MRI showed multiple nerve thickenings, which has been well mentioned. And third thing is family history was present and deformity present. So he had both subacute worsening, acute worsening with chronic on the top of chronic illness. Second comment is that Wes, we sent whole exome sequences. I am not an expert on genetics, but to the best of my knowledge, Wes is not one of the best tests to send for the PMP duplication per se. But this turned out to be positive in this case, and it was given in the Wes report only. So, do we need to send separate genetic test, or this Wes is enough? This is a question I pose to the people who are better versed in the genetics. But we discussed with the lab over the phone, and they did under the same cost. Possibly they applied some different technique within that same cost. And seeing the severe inflammation treatment, we started IV steroid. There was no response on the short-term treatment of 1 month. We also gave this thing. So should we give further immunomodulation in this case? Should we try or should we stop here in what the, and this is a open question. Maybe it will help. Audience answers will help the patients also. So with the short comments, I will, after 1 month, there was no improvement in the NCS. That is very clear. So with that, one last comment, yes. Father and mother were called, they were examined, NCS was abnormal, we could find the deformities. But when we asked the attendants, father and mother, they were adamant that no, they don't have illness. Why are you calling us? Why are you testing us? Almost getting close to the fight. So a normal family history is not normal till you have yourself examined the parents, done the test. So be very thorough about this and be very particular about this. Don't trust the history given by the attendants and the patients. Their NCS were clearly abnormal. Despite all these things, despite showing the patient's father and mother, they couldn't be convinced that they were abnormal. So with this, I will give the baton back to the chairpersons and the comments for the audience.
Vaibhav?
One small question. Dr. Mishra sir is here. In this patient, will doing a dispersion, looking for dispersion on the CMAP help, sir? Professor UK Mishra, sir.
Thank you for your question.
Will looking for dispersion.
Audible. So,
yes, sir,
very
you are
nice
audible,
case. Yeah, very nice case, very nicely presented. Everything great about.
You're not audible, sir.
Professor UKM, you're not audible.
Sir, connection gone wrong. He's stuck.
Before he comes on, can I ask a question, Vaibhav?
Sir, can I put the comment on that sir's question? Actually, temporal dispersion, all these things are not expected here.
Yeah.
Unfortunately, we don't have conduction. We don't have that. We haven't seen the duration. We should have seen it, but that is not expected here. But In PMP22 depression cell, conduction block itself is not expected, but we can clearly see conduction velocity is below 15 and conduction blocks both in the same case of genetically proven PMP22 duplication. So I don't think that they are fixed to one
Am
variant
I
or other
audible?
variations can be.
Am I
Yes, sir.
audible?
Yes, sir. Yes, sir. Now you're audible, sir.
I'm very little time because I'm a diptera. I think very nice case I enjoyed, and no doubt is a familial ability is present, no doubt about genetic disorder. But since there is acute worsening, and
So now your signal is lost, sir.
Vaibhav, can I ask a question in between?
Yes, yes.
See, the symmetricity of the conduction studies, would it favor more of a HMSN rather than a CIDP?
So there is absolutely no doubt that he has HMSN, neither historically nor the clinically and genetically proven also. The question is whether he has added CIDP or not and whether he has added superinflammation or not. The biopsy says no.
Why do we bring in CIDP at all?
So because the worsening was very rapid. Within 8 months, his upper limbs were involved. He had got severe, like this conduction blocks, which are not mentioned in the this thing. The CSF protein is 800, more than 800.
Yeah, but that was done only once.
So, means CSF is bit invasive. How often to repeat? We are actually planning to repeat it once. Now after one month period, we will recall this patient, repeat it, but it seems reliable.
Vaibhav, am I audible?
Yes,
Okay.
yes, sir.
Yes, sir, I may repeat it again. So, very good case, enjoyed every bit of it, but I would like to give him steroid 30 milligram and re-evaluate after 6 weeks. If there is any improvement, that's also IDP. If not, well, there was no other treatment offered. But because I have heard and seen people saying that this HSMN and differentiation with CIDP is very difficult. And you got many features. Protein is high, you got conduction block, and orthogenetic disorder is there. And Peter Dick also I've heard him saying that you must give steroid to these patients. So maybe you can try and see if there's some improvement or not. I won't give IVIG too expensive, but steroid can be given.
Steroid we gave for 1 month, sir, but he has not responded till now.
Not responded, give it for one more month and then discard it. Okay. Yeah, because we should give a chance.
UKM, what about rituximab?
You see, I'm scared of rituximab because I've had bad experience in fellow patients. So I avoid using it. Steroid is safe and most effective probably. Rituximab, personally, some of my patients did bad, so I avoid, personally. Otherwise, because we don't have very strong evidence either, but we want to say that some acute worsening and blocks, and so why not give him a chance for with steroid? But very good case. Let us know if he really doesn't improve or improves. You must inform me.
Thank you,
We will
sir,
give
for a
for a
very
short
interesting
term.
case, Sanjay. Vaibhav, thank you very much. And
Yes,
thank
sir.
you,
So we
Saranya.
will go for the second case, sir.
Yes, please.
Yes.
Dr. Ramkumar from Jitman. Hello?
So we will proceed with the second case, sir.
Yes, yes.
So, Soumya, you can go ahead.
So second case will be
Second case.
taken up by Ramkumar and Jairam.
Sir, this is Dr. Ramkumar from Jitman. Hello? Are you able to hear me?
Yeah, Ramkumar, you're audible. Please proceed.
Hello, sir. I would like to make a comment. Actually, there are some HMSN secondary to MPS mutations which mimic like CADP and they are responsive to steroids also.
Yeah, right. But here it is. We have a PMP duplication genetic report.
Yeah. That's what I I just wanted to make a comment regarding that.
Yeah, correct, right. That MPZ report and especially that CMTX also. But somehow, yeah. So
Okay,
please proceed with your case. You can share your.
No, sir. Jairam will be presenting, then I will be presenting later.
Good afternoon, respected sirs and madam. Today I will be presenting a case that is wobble and jerk, a dance of neurological intrigue. My moderator is Dr. Ramkumar sir. So 29-year woman, no comorbidities, studied 12th standard, homemaker, is presented with complaints of swaying while walking for 5 years duration, and involuntary jerky movements of both lower limb and upper limb for 5 years, and slurring of speech and seizures for 3 years duration. So initially she had a swaying while walking for 5 years. She had difficulty in negotiating narrow path, especially while traveling in a bus, while negotiating narrow path between seats in a bus. And when she is trying to climb the stairs, she is able to lift the leg, but unable to place in the intended place. And she needs support of bars to climb the steps. And she had difficulty in balancing and trying to drive a two-wheeler. And she had difficulty in walking and negotiating inside the house and climbing the steps. And this was very progressive. And she had a progress to inability to walk alone in the past 1 year. And she need attender support to walk in the last 1 year. Initially, it started with swaying of the lower limb, but progress to involve the trunk and bilateral upper limbs in the last 3 years. So she had difficulty in holding the pen and writing. She had difficulty in holding the keys and introducing it into the holes of the door and opening it. And she also had a difficulty in holding a glass of water and taking to the mouth. There is spillage of water and smearing of food around the mouth. And she also had a history of falls due to swaying. And there is no aggravation of symptoms on dark or closing the eyes. And when she goes to crowded places, there is increased bilateral lower limb tremors, aggravation of symptoms, which were intermittent, episodic, lasting for 10 minutes duration, and relieved with rest or sitting down, and aggravated on walking, climbing during the times of stress. However, the lower limb sensations were normal, no history of falls or aggravation of symptoms on closing the eyes or in dark. And she also had bilateral lower limb involuntary jerky movements for 5 years, which were intermittent, rapid, sudden, shock-like jerky movements of the lower limbs, more on doing the tasks and relieved with rest, and it disappears during sleep. And these jerky movements aggravated on sudden loud noise. And this progress to involve the upper limb, like upper limb jerky movements for the past 3 years, like dropping of objects suddenly, which increased over the last 3 years. However, there is no specific diurnal variation. Due to this moment, she had difficulty in cutting the vegetables and difficulty in holding the glass or cup of water or mixing the foods. Its fine upper limb movements are affected. And there is no loss of consciousness during these events. And she also had slurring of speech for 3 years, like insidious onset, gradually progressive. Comprehension is normal. She is able to speak syllable by syllable. But no history of any bulbar symptoms like dysphagia, nasal regurgitation, choking, coughing while eating, bulbar or lower cranial nerve symptoms. And she had the seizures for 3 years duration. Two semiologies are there for seizures. First semiology is, it began with the pulling sensation of the right lower limb, sensory aura, and following that she had a loud vocal cry, loss of consciousness, uprolling of eyes, and posturing of head to left side, associated with tongue bite lasting for 2 to 3 minutes, and followed by postictal confusion for 5 minutes. No clustering, diurnal variation or urinary incontinence, and frequency is 1 episode per month and 4 episodes total till date, and last attack is in January 2024. So it began as a right focal to bilateral tonic-clonic seizures, and second semiology is myoclonic jerks. So no history of any nystagmus, oscillopsia, no history of a facial deviation, cranial nerve palsy, no history of sensory loss, fever, headache, raised ICT features, no history of any other abnormal movements like rigidity, dystonia, or behavioral changes, anger outburst, no history of memory loss or rapid cognitive decline or slowness of active movements, no history of any suicidal ideation or depression. A past history, no history of comorbidities like diabetes, hypertension, tuberculosis, bronchial asthma, or liver disease. And the aggravation of the tremblousness and myoclonic jerk during the deliveries, like first delivery happened 3 years back and second delivery 1 year back. And in the postpartum period and the pregnancies, there was aggravation of these symptoms of tremblousness and myoclonic jerks. And she was diagnosed as hypothyroidism during the first pregnancy and she was treated. And she received propranolol, levetiracetam, and multivitamins. She was evaluated in outside hospital, and during that time, this anti-TPO titer was 114. It's not very significantly elevated. Normally, 2 to 3 times upper limit of normal is considered significant. And also, it should correlate with the clinical of ruling out other secondary causes. And if there is any subacute encephalopathy, which is explaining, then Hashimoto's encephalopathy or SRIAD is considered. But however, since the titers were in the borderline, mild elevation is there. They considered trial of oral steroid, but there is no significant improvement with steroids in outside hospital. In family history, she born out of a non-consanguineous marriage, history of diabetes in both the parents, She has 2 boys and no history of any similar complaints among the family members. Personal history, normal. She's a non-vegetarian, normal bowel and bladder habits, normal sleep and appetite, no addictions. So this is the timeline of symptoms. So initially, 5 years back, it started with the swaying while walking, and following that, she had a progression of the swaying from lower limb to involvement of trunk and upper limb, and she also had involuntary jerky movements of bilateral lower limb. And over the past 3 years, it has increased to involve the upper limbs, which is multifocal distal predominant. And in the last 3 years, she had seizures. That is two semiologies. One is right focal to bilateral tonic-clonic, and other is myoclonic jerks. And the 3 years, she had a scanning speech, probably cerebellar dysarthria, and all these symptoms are progressive. So we had 3 symptom complex in this. One is progressive ataxia. Second is for 5 years duration, and the second is myoclonic jerks. And following that, she had seizures. So summary: 29-year-old women with insidious onset, gradually progressive swaying while walking, tremblousness while handling the objects, and progress to trunk and bilateral upper limbs for 5 years. With the dysarthria, that is scanning and slurred speech for 3 years. With bilateral upper limb and lower limb jerky movements with the right focal to bilateral tonic-clonic seizures. With normal higher mental function, cranial nerve, sensory, and bowel and bladder. So syndromic diagnosis is 29-year female with progressive symmetrical cerebellar ataxia, that is limb and gait ataxia with the dysarthria, and myoclonic jerks and seizures for 3 years duration. And probable localization is gait, truncal and appendicular ataxia, cerebellum and its connection. Scanning speech, left superior paravermian area of cerebellum. Right focal to bilateral tonic-clonic seizures, probably left parietal region. And myoclonic jerks, since it's distal predominant multifocal myoclonus, and predominantly its action induced or stimulus sensitive, it is probably a cortical myoclonus, so localized to cerebral cortex. So a differential diagnosis considered was, since it's a young female with progressive ataxia, seizures, and myoclonus, so initially we considered a mitochondrial, that is MERF and Pol-G mutations. However, there is no visual complaints, hearing loss, family history, or migraine. And second thing is progressive myoclonus ataxia spectrum disorders like Lafora body disease, Ullrich-Lundberg disease. Since she had myoclonus, progressive ataxia, seizures, and slurred speech. But the odd point is she does not have any rapid cognitive decline is not there. No drop attacks or organomegaly. And other infections considered were SSPE. However, there is no history of any exanthus measles infection in childhood. No history of cognitive decline or behavioral personality changes. And CJD is also considered. Since two variants is there, one is Brownell-Lopana variant. This presents predominantly with the cerebellar ataxia as the predominant features, and myoclonus and seizure is there. Our patient does not have any psychiatric manifestations or dementia. So Brownell-Lopana variant of sporadic CJD can be considered. And other differentials considered were lysosomal storage disorders like sialidosis, metachromatic leukodystrophy, Niemann-Pick, Sandoff, and Gaucher's. Like progressive ataxia, seizures, or myoclonus in a young female with a normal cognition. So normal cognition, all these metabolic storage disorders can have normal cognition. However, there is no vertical gaze palsy or gelastic cataplexy or facial dysmorphism or organomegaly, macroglossia. And DRPLA can also be considered since patients has the triad of seizures, ataxia, and myoclonus. However, there is no chorioathetosis, dementia, or significant family history. And neuronal ceroid lipofuscinosis, adult variant, that is type 3 Cuffs disease, can present with these features like ataxia, myoclonus, and seizures. However, there is no blindness or mental deterioration or cognitive decline. And Huntington's disease can be considered, but there is no suicidal ideation, depression, or behavioral changes or chorea. And Hashimoto's encephalopathy can be considered. However, there is no subacute encephalopathy or psychiatric symptoms, and there is also no significant response to steroids. So these were the differential diagnosis considered. So here the normal cognition is a very important thing because it helps in differentiating from SSPE, progressive myoclonic ataxia spectrum disorders like Lafora body disease, and along with that this neuronal ceroid lipofuscinosis and Huntington's disease and Hashimoto's encephalopathy. So now on moving to examination, patient is conscious, oriented, afebrile, vitals were stable, no neurocutaneous markers. And neurological examination, GCS was E4, B5, M6. Higher mental functions were normal. MMSE score was full. And the cranial nerve examinations were normal. Bilateral pupils were 3 mm reacting to light. Visual acuity 6/6. No KF ring. Fundus, no cherry red spot, retinitis pigmentosa or optic atrophy. Saccades and pursuits were normal. No facial palsy. and the lower limb hypotonia was present. Our upper limb tone was normal, and power is 5/5 in all 4 limbs. And deep tendon reflexes were 2+, no asymmetry. Sensory examination was normal. And cerebellar examination, no nystagmus was there, but bilateral finger nose test, finger nose test impaired, and knee heel test is impaired. No dysadacokinesia, and truncal ataxia and scanning speech is present, which I will be showing in the video. So this is the resting position, and this is sustained position. We can see the left-sided jerky movements. You can see the left-sided myoclonic jerks. There is a asymmetry, left more than right. So it is stimulus sensitive. So on touching the left upper limb, there is a increased myoclonic jerks. When compared to right side, left side finger nose test is positive. So here you can see there is a left more than right asymmetry, and then this myoclonic jerks at rest, sustained posture, and along with that on active as well as passive movements, and stimulus sensitive. On touch, the movements are more on the left side, and cerebellar symptoms, finger nose test and scanning speech are demonstrated. So here the gait of the patient is demonstrated in this. So here you can see there is a wide-based gait. She has hesitancy in placing the next step, and there is some difficulty in turning. Here we see a sudden jerky orthostatic myoclonus. And she needs support of the nearby objects to turn around. And she's not able to do tandem walking. Even with supports, she tried, but she's not able to do tandem walking. So from the video, we can understand that involuntary distal predominant multifocal irregular jerky movements, which are action induced, stimulus sensitive to touch, and disappears during sleep. All this favors the cortical myoclonus. Bilateral, that is, but here it is left more than right upper limbs, and it involves the lower limbs also. We saw orthostatic myoclonus while the patient is walking. And other spine and cranium examinations were normal, no meningeal signs, and other system examinations were normal, no organomegaly. Summary: it's a 28-year female born out of the non-consanguineous marriage. The history of progressive cerebellar, truncal, and gait ataxia for 5 years duration, and cortical myoclonus for 5 years. Distal predominant, multifocal, stimulus sensitive, aggravated by touch, sound, and passive movements. And patient had a right focal to bilateral tonic-clonic seizures for 3 years, cerebellar dysarthria for 3 years, with a normal higher mental function, cranial nerve, sensory, motor, bladder, and bowel. So from this, our differential diagnosis after examination, what is mitochondrial we can consider. Since a young female with progressive ataxia seizure myoclonus with normal cognition. However, there is no retinitis pigmentosa or optic atrophy. And progressive myoclonus ataxia spectrum, LaFora body can be considered, but the odd point is patient does not, like, cognition is normal, there is no cognitive decline or organomegaly. And CJD can be considered, but here also there is no progressive dementia. And other metabolic lysosomal storage disorders like sialidosis, Gaucher's, Niemann-Pick's can be considered since the patient has normal cognition with progressive ataxia and myoclonus. And DRPLA can be considered, but no coriform movements or dementia. And NCL, usually patient will have this rapidly progressive cognitive decline with the pyramidal signs and blindness, but here it is not there. And Huntington's disease, however, there is no behavioral changes, psychiatric manifestation, slow saccades, chorea, or suicidal ideation or family history. And SSPE, but SSPE usually has a slow relaxing kind of myoclonus and cognitive decline. But here cognition is normal and it is a cortical myoclonus, so it can be pushed to lost. And SRE, like steroid responsive encephalopathy with autoimmune thyroiditis, that Hashimoto encephalopathy, it's very less likely because here there is no subacute encephalopathy, cognition is normal, and the patient also not respond to steroids. And there is no, however, there is no psychiatric symptoms. So
in your small in your differentials, did you consider any, because it's a long-standing history, so CJD and all should not be, I think, must be much lower. So did you consider other differentials like any scars which can present with epilepsy and myoclonus? Also, especially in Tamil Nadu, ADCME also should be considered. I don't know whether ADCME can have prominent cerebellar features that too. So these other two differentials also should be, ADCM is especially seen in Nadar community. So I don't know, this patient is from Tamil Nadu, right?
Yes, sir, from Tamil Nadu only.
Family history should be there, man.
Family history is not there and pyramidal features are also not there.
Family history is not there. Can be. Yeah, you can proceed.
Sir. So proceeding with the investigations, hemogram with peripheral smear showed normocytic normochromic blood picture, no acanthocytes or blast or atypical cells. Renal function, liver function tests were normal, ceruloplasmins were normal, tumor markers were negative, and B12, vitamin E, folate levels were normal, HbA1c was normal, fundus and putron audiometry was normal, TFT was also within normal range, and outside MRI brain imaging showed normal except for mild cerebellar atrophy, and nerve conduction study was normal, and EEG was also normal, alpha rate background activity, no periodic short wave complexes or epileptiform discharges. And we proceeded with skin biopsy. The skin biopsy from axillary region, no LaFora bodies was there. And fundus was normal, no cherry red spots or retinitis pigmentosa. And the VP showed prolonged P100 latencies in this patient. However, the OCT was normal. And SSEP showed high amplitude giant waveforms, that is 15 to 50 microvolts, suggestive of cortical myoclonus. So here we can see this is the normal SSEP and this is our patient's SSEP. Normally this waveform should be less than 5 microvolts within this one box. But here we can see that it is very huge and giant with a large amplitude, approximately around 35 microvolts. So more than 15 to 50 microvolts is considered as giant SSEP, which is more suggestive of cortical myoclonus as in our patient. And we proceeded with the whole exome sequencing with the mitochondrial panel. Mitochondrial panel turned out to be negative for coenzyme Q10, POLG, and other mitochondrial disorders. And it turned out, whole exome sequencing turned out positive for neuraminidase 1 gene, which is homozygous mutation in the exon 5. And the sialidosis type 1 with autosomal recessive inheritance has been revealed. So sialidosis, basically sialic acid is basically a 9-carbon monosaccharide which is attached to the terminal end of glycoproteins.
Jairam,
And this,
Jairam,
sir,
Jairam, I will be dealing with what's like theory about sialidosis. So
okay, sir.
no need to.
Yes, sir. So when to consider sialidosis, the positive findings in our patients are it's a young patient with progressive cerebellar ataxia, cortical myoclonus, and right focal to bilateral tonic-clonic seizures with a normal cognition and cherry red spots. So cherry red spots can be present in 75% of the patient. and 25% of the patients may not have cherry red spot. And our patients also had a prolonged visual level potential and high amplitude giant SSEP suggest of cortical myoclonus. So after ruling out the causes like progressive myoclonus ataxia, and CJD, Hashimoto's encephalopathy, SSPE, and mitochondrial diseases and other common condition. If the patient is a young patient with progressive ataxia, cortical myoclonus, with normal cognition and cherry red spots, and we have to consider sialidosis. The odd point in this is the cortical myoclonus is slightly asymmetric left more than right. And other thing is patient had a right, usually the seizures are generalized, but here it's a right focal to bilateral tonic-clonic seizures. And this normal cognition is very, very important in differentiating from other diseases like SSP, progressive myoclonic ataxia spectrum. So two forms are there. Our patient comes under type 1. It's a mild late
Jairam, that's
form.
what, no? Jairam?
Oh, okay.
I'll be speaking about.
Okay.
So no need to go into theory.
So I will like to hand over to Dr. Ramkumar sir for discussing further about sialidosis.
No.
Any comments before proceeding to my presentation?
Ram, I have a small question. Means it's just of a comment. We send West plus mitochondrial or West itself showed sialidosis. Means mitochondrial analysis was additionally sent.
Yeah, it was sent, sir.
So we sent both West and mitochondrial, no?
Yes, sir.
Yes, sir.
Yeah, just to give to the audience that mitochondrial is not covered under West. So if you are suspecting a mitochondrial strongly, you have to send it separately. And sometimes if you talk to the lab, they will give huge discount if you are sending both together. So if you want to send them, send it at one go. Discuss with the lab and maybe they can take 2,000 rupees more, but they will do both together. Yeah, please, Ram, please continue. Yeah.
Was there any abnormality in the retina?
No, sir. Fundus was normal.
Oh, okay. Thank you.
Thank you.
Is my slides seen? Are my slides seen?
No, you are seen.
Slides, sir?
No,
you are
not
seen.
seen.
The slides are not seen. You have to share that.
I'm showing. How's it?
Yes, now they can see.
Now,
Yes.
Okay. The reason we presented this case is because sialidosis is quite a rare disease.
Yes.
If you see, only few cases have been reported from India, but also from all over the world also only few cases have been reported. So to sensitize the audience regarding keeping sialidosis in the differential diagnosis, that's the reason for presenting this case. So I will be presenting very briefly, like I don't want to be a huge theory and that because basically it's a clinical neurology forum. So I will be just presenting briefly about sialidosis. Sialidosis is an autosomal recessive disease, and it is caused by the genetic defect in the neuroamylase gene. That is it is occurred in the 6p21.3. What is neuroamylase? It is an enzyme which just breaks up on this glycoconjugates. But it breaks the terminal cyanic residues and then breaks its glycoconjugates and then metabolize system. So the deficiency of this leads to the accumulation of these glycoconjugates, which leads to this disease. So it's basically a deficiency of the neuroamylase 1. And before, actually in the past, sialidosis was predominantly associated with the type 2 disease. Later on only they found out about type 1. Type 1 is normomorphic and type 2 is dysmorphic. Type 2 is usually present at an younger age, like you can even present at birth or also even as low as 2 years, all those things. And the dysmorphic features will be like usually coarse facial features, Hurler type of features, and some bony distortions will be present. But these things will be absent in sialidosis because later only they discovered type 1 sialidosis. And a few things about the pathogenesis. This is basically due to the neuroamylase 1 deficiency. So it leads to it regulates the lysosomal associated membrane protein. And due to the dysregulation, the LAMP1, the concentration of LAMP1 increases, and this leads to the lysosomal exocytosis. And this is the reason for all the pathogenesis seen in this disease, which leads to this changes in cell characteristics as well as the PM, plasma membrane remodeling and aberrant signaling, and leads to organ pathogenesis. And it usually starts in the second or third decade. As I said previously, this differs from the cyanosis type 2, which is a dysmorphic one. And this presents usually in the second or third decade. And the predominant clinical features as seen from our case also, it is usually myoclonus and seizures, ataxia, and blurred vision, with myoclonus and seizures being present almost in 96% of the patients. Other less symptoms, less common symptoms might be dysarthria, dysphagia, hearing loss, cognitive impairment, or intentional tremors. So the myoclonus is basically cortical, as it is seen from the giant SSCPs, and the action myoclonus is limbs jerky movement. And as we've seen in cortical myoclonus, it can be triggered with tapping or pin pricking, lighting, or loud sound. And as the Jairam pointed out, the predominant seizures will be GTCS or myoclonic seizures. But in our case, there is some variation from the same. So now coming to the absence of cherry red spot in our case, as you can see from this particle, there is a difference between cyanosis in Asian patients from the non-Asian patients. As you can see from this slide, Asian patients usually have less cherry red spots. As in from the study, only some 40.7% of the patients from Asia had less cherry red spots. And the reason they say is cherry red spots is usually due to the there will be enzyme activity of neurons will be more. Actually, if it is less only, the cherry red spots will develop. That's one theory, but it's not always the case, because they found that even when the neurons activity is more also, less also there was some cherry red spots were there. And it can be attributed to some genetic factors or environmental factors also. And there are some difference between the early onset as well as the late onset cases. In this, the cherry red spot is usually more in early onset cases, and with also the ataxia and seizures are also more in the early onset cases, plus the visual symptoms. And this is the typical cherry red spot seen in sialosis. Other differential diagnosis for cherry red spots may be Tay-Sachs disease, then GM1 gangliosidosis, then sialosis also is one of the things, then Sandoff disease, then metachromatic leukodystrophy, and the other things for cherry red spot. So why this occurs? This occurs mainly due to the deposition of material in the ganglion cells of the retina at the macula. Since these ganglion cells are absent in the fovea, this area has a relative transparency. So the surrounding opaque retina contrasts with this one, and this is the reason for the cherry red spot. And other than investigations which can be done in the sialosis is light and electron microscopy, which shows this cytoplasmic vacuolation in the neurons and perineural interfascicular oligodendroglia and periepithelial cells. And these vacuolations are due to this, as I said, the accumulation of this intracytoplasmic lipofuscin-like pigment that can be seen in various areas of the brain, as well as thalamus, basal ganglia, and cord. These also can be deposited in extra nervous organs, which is the reason for the organomegaly like epiplosmenomegaly seen in sialosis. And other tests which can be done, thin layer chromatography, which is a screening test which can show this abnormal urinary oligosaccharide pattern, as well as the peripheral smear or blood can show the storage granules in the lymphocytes. And in the skin biopsy, lysosomal activity, decreased lysosomal activity can be seen in cultured skin fibroblasts. But the final diagnosis will always be genetic, and it is usually due to NUV1 mutations. And there are more than 50 mutations reported in worldwide. Other investigations are EEG, which can show spikes and spike complexes, as polyspike waves, or increased beta activity. And one peculiar EEG finding which has been reported in sialosis is this spiky beta brush. Which, as you can see, this is a spiky beta brush which is seen in the EEG. This is one of the peculiar findings which has been reported in sialosis. And as in our case, there can be giant SSCPs in the median as well as the tibial nerves. Then the VEP can be prolonged. And also this enhanced long loop C reflexes can be also seen. Long loop reflexes or C reflexes are usually cortical reflexes, which are usually lesser, have a longer latency than the spinal reflexes, but will be lesser than the voluntary motor reflexes. And these also can be enhanced in sialosis. And one of the few, there are only few studies which have evaluated nerve conduction studies in sialosis. And these studies have reported predominantly the mixed type sensory motor polyneuropathy pattern. And there can be also increased F latency plus repeated FAs. What is repeated FAs? All the FAs will be similar in amplitude, latency, or morphology. These also can be seen in sialosis, but this is not in our case. And OCT can show macula, it can show the increased RNF thickness. This is due to the accumulation of sialo-oligosaccharides. And the what are the reflectivity which is seen, I think we can see in the next one. This is the increased reflectivity which is seen in the OCT.
Yeah, that is curious. I think the RNFL in most of the pathologies, the RNFL thickness goes down, right?
Sir, or sir?
In the OCT, most of the cases, RNFL thickness goes down.
Yes, sir. Yes, sir.
Here it goes up, right?
Yeah, it goes upside, but it is like yeah.
So most other pathologies like mitochondrial and other things, if you see that it goes down.
That's what, sir. As I said,
think.
no, this RFNL thickness is due to the accumulation of the sialo-oligosaccharides. These sialo-oligosaccharides get deposited in all over even in neurons as well as in extraneuronal organs.
Okay.
So that is the reason.
Yeah, that's an interesting fact. Yeah, please continue.
Yeah, another interesting thing which I didn't tell during my pathogenesis, this neuroramidase deficiency, all those things can also be implicated as some cross relation with Alzheimer's disease also. So that's
you have not projected the EEG of our case, but that in the EEG was what was the EEG findings? Was this brush present in our EEG case?
I think in
that
our case,
brush
the
you
EEG
mentioned in the EEG, was that brush present in our case in the EEG?
No, I think our EEG is normal, sir.
Our EEG is normal. Yeah, that's what I remember Jaram telling me.
Yeah, the spiky brush will be like seen typically, but in our case it will not see.
But despite so much myoclonus and everything, normal EEG is also it's a curious thing.
Yeah,
Although cognition is not involved, but despite so much myoclonus clinically subjectively seen, cortical myoclonus, but EEG was completely normal.
Yes, sir. It can be normal. EEG can be normal.
Yeah.
Yes. But the spiky beta brush is one peculiar thing they have shown. And this is due to the apparent increased reflectivity of the photoreceptor layer in the foveal region with relative decreased reflectivity of the outer retinal layers. And this is caused by thickening and increased reflectivity of the aura funnel of the inner retina in the adjacent macular region. And brain MRI can be normal in early stages, but various atrophy of cortex, pons, cerebellum can be seen, with cerebellar atrophy being reported in most of the cases. There can be also frontotemporal encephalomalacia or cerebellar meningocele. And the treatment is usually anti-seizure medications with valproate, levetiracetam, phenobarbital, zonisamide, perampanel, and benzodiazepine. And one thing which the residents particularly must be aware of is that you must avoid carbamazepine, phenytoin, and also lamotrigine also must be avoided in these cases. And there is actually the myoclonus. Sir?
Because of myoclonus, you are saying those should be avoided?
Yes, sir. Yes, sir. So myoclonus, so carbamazepine, phenytoin must be avoided. So also lamotrigine also must be avoided. Actually, this if you see compared with sialosis type 2,
lamotrigine also exacerbates the myoclonus. That's what you're saying, or some other reason?
No, sir. Actually, lamotrigine can be given in myoclonus, but in this case, it usually worsens the myoclonus. That's what it has been given in the literature. And one other thing which I want to say is that sialosis type 2, in contrast with type 1, is usually starts from the younger age and it's usually very severe and the patients are quite morbid and mortality is more. But sialosis type 1 is relatively innocuous. They will have this slow, not slow, myoclonus, ataxia, seizures, which can develop slowly. And they can have a near normal life also. But what happens is their quality of life is very much compromised, particularly with regard to the myoclonus, which is very much severe sometimes in sialosis type 1. So what they have found is there is one study, I didn't find many studies, but this study pointed out that after the use of perampanel, even in spite of using the previous medications which are saying they didn't resolve, but after the use of perampanel, this patient had a good response to the myoclonus, very much responsive. So this perampanel must be always tried in sialosis in recalcitrant myoclonus.
And our cases fits into which one? One or two?
One, sir, and ours is one.
One.
Usually type no. Yeah, one. Yeah, type 2 is usually very severe. Starts in the
that's what I thought.
Yeah.
Okay.
So As far as now, there is no
So anyway,
therapy for
ataxia and myoclonus both are very disturbing in our case also. Despite being one, it is not like she is conducting normal activity.
yes, sir.
It may be
I
much
think it
less
can be.
severe than that too, but still it affects the quality of life.
Yeah, and there are some atypical cases of sialosis in which only the myoclonus alone is only reported. Subsequently, while doing the genetic diagnosis, they found out that it was due to sialosis, and further investigations only gave some additional information regarding the diagnosis of sialosis. So sometimes myoclonus can be very much the only symptom also, sir. So basically, apart from treating the myoclonus, there is not much therapy for sialosis. Some therapies can, or which has been like tried in
The
rats
seizures
only.
have
There are
also been
no.
mentioned in sialosis.
Yes, sir. Seizures. Usually, seizures will be like
Other
GTCs
than
or
myoclonus, I'm talking
myoclonic.
about other than myoclonic drugs.
Yes, sir. Myoclonic seizures will also be there in sialosis. Other seizures are not much. More basically, bilateral tonic-clonic seizures
Our patient had
or myoclonic.
two types of seizures. No, one is myoclonic jerks and other is
Yeah. I think our patient basically myoclonic jerks. I think she didn't have myoclonic seizures. She had this right focal to bilateral tonic-clonic, which is somewhat different. Usually, it will be bilateral tonic-clonic seizures and myoclonic seizures. These will be the predominant seizure types in sialosis. As
and
against the multiple.
there was no corresponding lesion in the MRI to that focal
Yeah.
seizure.
No, sir. That's what, no, as I told, like the memory will be normal in most cases. Some atrophy can be present. In this, cerebral atrophy is usually common.
Yeah, so we found a
So,
focal patient, therefore I was asking, yes.
yeah. That's so, but we didn't find any focus in EEG as well as the neuroimaging.
Yes.
So since like sialosis, the only treatment is we can treat the seizures as well as the myoclonus. Apart from that, we cannot do much thing. There are no human trials, but there are some trials in mice. One is this study which shows the AAV-mediated gene therapy sialosis, and it's reduced the neuron activity in most of the tissues, and also decreases the lysosomal vacuolation. Plus, there was the normalization of the lysosomal exocytosis, which is one of the main contributors as we discovered in our pathogenesis. This is another recent study in which the gene therapy corrected the previous study. They didn't see the clinical features, but this study they corrected some of the neurological deficits of mice. So it showed some improved grip strength or improved rotor rod performance, and it was achieved by the cerebrospinal fluid delivery of this AAV vector in a gene therapy. And there is not much studies regarding the DBS, but there is only one study, which was because the myoclonus sometimes myoclonus dystonia, GPA stimulation has been tried. So in this case, the authors tried bilateral GPA stimulation in myoclonus. But there are some improvements. So this also can be kept in the pipeline. So these are some of the other studies which people can refer. I just put for reference purpose. Thank you.
Thank you, Dr. Ankumar. Thank you very much.
So we have finished much before our time, sir.
Yes, sir.
So we have got put time for discussion.
Correct. You could have added one more case also. Yes, sir. We have finished well in time.
Well in time, yes.
That's because you went on to investigations and you discussed in full without pausing.
Yeah, we had like a combination of one rare case as well as one diagnostic dilemma.
Yes,
so that way that could be there could be variety as well as the learning. Because like only I think 2 or 3 cases from India have been reported sialosis.
Your voice is
So
not
we
clear,
are
sir.
also.
It's audible, but it was not clear.
Vaibhav, in the comment box now, there's one interesting comment. Whether your first case can be like a nodopathy.
Yes, I had responded to that. So the approach to is first to diagnose CIDP, then to establish that it's a atypical CIDP. When you establish that it's atypical, then you go for a nodopathy evaluation. Nodopathy evaluation is very costly. It's not a simple garden variety is available with difficulty. We are still not convinced it has CIDP or not, it has CIDP component or not, but it definitely has an inflammation component. So as Mishra suggested, we will try to give him a steroid trial again once. But again, if it's in nodopathy, it won't respond to the steroid that well. We went as far as biopsy also in this case. We get some inflammation, but the inflammatory markers are not seen in the biopsy also. So actually, we are stuck in this case as of now. So maybe because subacute worsening has been described in literature, but nobody tries to explain why it happens. They call it subacute, but in the 8 months, for last so many years, he has been stable, but within 8 months, his upper limbs are also involved. So subacute, but it's very rapid. Why this happens, I'm unable to fathom this phenomenon happening.
Yeah, hello. This is regarding the first case with the trigeminal nerve involvement. Now, was this a trigeminal neuralgia or a trigeminal neuropathy? Was there numbness, or was there a constant burning, or was there a jabbing pain?
It was a typical trigeminal neuralgia, sir. There was no neuropathy. And the MRI also got the vascular loop surrounding the right trigeminal nerve. Thank you.
Okay.
I think if there are no other questions, shall we close, sir? Vian, sir?
Yeah, I just wanted to know would there be any difference if it were a neuropathy, if it were a nodopathy? You get out classical electrophysiological changes which were seen in this patient?
Sir, can you repeat, sir?
If it were to be a nodopathy, would you see those classical electrophysiological changes we saw in this patient?
Classical?
Electrophysiological features which we saw in this patient.
In the nodopathy, the classical feature seen for the electrophysiological is rapidly reversible conduction blocks. So this is a chronic process. Even if the electrophysiology of the CIDP happens, how the baseline HMSN will affect it, we don't know. The only feature that is favor of nodopathy, if we evaluate it as a nodopathy, are that presence of sensory ataxia, atypical age, and rapid progression of the disease. So yes, if there was no HMSN in this case.
Yeah.
And had this case presented to me as a CIDP, I would have gone in for the nodopathy assessment if the patient was affordable. But that whole presence of HMSN or all the reports of case subacute worsening is still tying me up because it will easily cause yeah.
Mute others, please. Okay, sorry, Vaibhav.
Yeah, because as sir suggested, I think we should give steroid trial and then repeat the all the parameter once. Maybe somewhat longer duration of steroid, maybe 3 months is needed to see the response.
Okay. If there are no other questions, yes, we might conclude.
So let me thank, first of all, Dr. V. Natarajan, sir, for initiating this wonderful.
Not at all. The presenters are to be thanked.
You initiated,
I have no role at all. Yes, please. Go ahead.
This thing, and also thank the JIPMA team for the two very challenging cases. And thank all the participants, and also wish to thank the Sun for supporting this and the technical team. Thank you, and I think Sir will be informing you regarding the next date. Thank you, all of you.